So just a little bit about me. I qualified at UCLan not too long ago, believe it or not. I'm not that old. I'm a GDP. I'm also an outreach tutor for Liverpool Uni. I have worked in the university as well. I'm an ES right now. Will be my last year being an ES, and I'm TPD for HU Northwest. And I'm also external advisor for the Health Service and Parliamentary Ombudsman, which is basically a service that helps patients deal with complaints. So I've got quite a good general work experience at the moment as well. So just so it's very clear, I am presenting from my own experience, and I'm not presenting from an organisation. This is just off me solely. But we're saying that though my opinions and my advice may be skewed by what I do. But I just need to make it clear it's not from. I'm not talking on behalf of HE or any other uni or a business or anything like that. Especially because I'm being recorded as well. So I believe you usually send questions in, so that's fine. I'm happy to be stopped, to ask any questions. If something doesn't make sense or you feel I'm going too quick, then let me know. So just jump into it. What is the FD year? So, it's there on the screen, really. That's what it's defined as by the curriculum, which is basically what everything is run off. It's run off the COP10 curriculum of 2015. And it says it there. It's basically to put you into a period of employment, into an approved training practice for 12 months. And it's really just to make sure that, you're competent, and the NHS in itself is happy for you to work in the NHS. That's basically what the FD year is for. Can I be, there's just someone that's got the microphone on. I can just get a little bit of feedback. You can just make sure your microphones are off. Thank you. So who manages the FD year? So at the moment it's HE. And that's what HE does. It's all for support, education. Interestingly, HE is going to disappear soon, and it will all merge into NHS England. So that will be by the time the 5th years, and that now will experience sort of a new structure, shall we say. So as it stands, HE receives funding for each FD in their area. They'll get so many FDs, usually say 125 we've got this year. And basically they get money, so the area gets loads of money, and then the area delegates the FD programme, and basically you go to educational supervisors, and most educational supervisors are GDPs. So sort of the structure, we've got the postgraduate dental dean, the associate dean, then there's five of me, and then there's educational supervisors. And the FD practice receives funds from Health Education England to cover costs. The educational supervisor gets a grant, and then obviously the FD gets paid as well, you'll be happy to know. And that currently, Sara is technically employed by the lead employer. You're not employed by the practice, you just work in the practice. Nafisa and HA1A325 at QMUL, can you turn your microphones off, please? Sorry, I can hear so much in the background. So why do you need to complete the FDA? Because it's a little bit sort of like, it's just automatic that you're going to do it. And I don't think I didn't question why I needed to do it. I don't know about you, Sara, but I didn't know why. And basically, to work in an NHS practice or any NHS contract, you need something called a performer number. And the most common way of getting a performer number is completing the FD year. That's basically simple. There's other ways, but we'll not go into that. And without a performer number, you can't carry out DCT. You can't work in an NHS practice. Even if you've been a well-experienced private dentist for 20 years, you still can't go and work for dental core training without your performer number. So the other thing is why you need to complete it is that at the end of the day, newly qualified are not really ready for purely independent practice, and that's why FD is becoming more structured as time's gone on. I don't know if you speak to your tutors years ago, there used to just be a handshake. You just walk up to a dentist and say, "Can I do my They used to call it VT. Can I do my VT year with you? And if you liked each other, it was just an agreement and you worked there and that was it. But now it's a little bit more robust. So when will you start or what happens? So 5th years, you're most probably already nearly going through this with the SJT. You don't have to have interviews this year, which is pretty good, I think, maybe. And then you'll make your choices. I'm sorry, but I don't know about you, Sara, but the 2021 intake had to list each practice individually. Did you have to do that?
So we did it in schemes, and then once you've got your scheme, we did the practices.
So schemes. Okay, so that's you. So sorry about that. I wasn't sure. So you will choose your schemes, which is usually geographically based, and then the area, like the Northwest, can decide how each FD and ES are then paired. Because I think because of COVID in 2021, they made FDs choose every practice. So hopefully you won't have to do that. So at the moment, HE is split up into 7 areas in England, and then Wales has its own sort of HE patch, shall we say. You'll start on the 1st of September. And basically when you start, you have a couple of days or a week or 2 of practice induction. You'll be given your study timetable. You just sort of get to know the practice, your ES, expectations, things like that. I'm sure Sara can speak about that in a bit to give you a bit of an idea. And it's sort of down to the practice, how you're inducted into the practice. You might see some patients on your first day. You may observe your ES. You may just do some admin. It's whatever your practice wants to do. No one will have the same induction. I know that for sure, but we all do it differently. And then historically, you're placed into schemes or groups, and usually you'll have study days with those groups. So right now in the Northwest, there are 5 schemes, and I won't name them out, but it's pretty self-explanatory. But I'm just going to let you know, in my opinion, is you should take, if you want to go to the Northwest, I would take these with a pinch of salt. Yeah, it doesn't always mean what it says, as in there's definitely overlaps of the schemes, and it might not impress some people. So don't be too set on where you're particularly going. I'd say that most of the Greater Manchester schemes are in Greater Manchester. Cheshire and Mersey tends to be a little bit hazy. South Cumbria and Lancs is my scheme right now, which Sara's on, and it's everywhere. It's very widespread. So, don't get too bogged down with that, unless the schemes have, really, really have been the same for years and years, but that's unlikely. So this is a lovely map of the Northwest of the current ES practices. So this gives you the range of where potentially you could be. And HE find it difficult because you can see you've got, see there, 2 circles in Wigan, which is a bit, in between Cheshire, Mersey, also in sort of Manchester way. Then you've got one in Warrington, a little bit in the middle. You've got practices in Crewe, practices in Lytham, Blackpool, Colne. So it really is widespread. So for example, Sara, you are in near Preston. Is that right? Sorry. Yeah. And she's in my scheme, but the exact same, the FD in Sara's scheme goes to a practice in Colne. So it's literally nowhere near each other. So just bear this in mind. And we have no control of this. It's just the way it is. There's nothing we can do about it. I assure you. I've tried. So why do the schemes change? So ES practices change every year. It's not a given that you're going to have the same practices. Some ESs will leave the practice for whatever reason. Some ESs just retire. It's just one of those things, and it can happen quite last minute as well. So it's quite a difficult process to go through, and it happens every year. The ES in the practice has quite a hard selection process. So when they get reviewed, if there's something majorly wrong, it might be that they can't actually be a practice. Something might be not too good, and HE have decided, no, you can't be an ES this year because of X, Y, Z. Then we have new practices who apply. And again, this changes the practices. So I'm just basically saying, don't rely on historic information. You'll have ESs who have been ESs for a long, long time, and they're most probably a bit of a given, but then other ESs will change. And also the other reason why it changes is because each year there's not a set number per area. So the Northwest and the South and the Northeast, they will bid for FD places. So it's a bit weird. It's not like it won't be exactly the same every year, which is a nightmare for everyone, including me. So unofficial update about the Northwest is that from next year, so that your this year's 5th years, if you're in the Northwest patch, there will be a skills lab and an education centre. And so from next year, all FDs in the patch will go to this location. So it doesn't matter what scheme you're in. So if you're in Cheshire and Mersey, you will go to this skills lab. And off the record, even though I'm being recorded, it will be in Altrincham. That's where it's being, that's where they're doing up the building at the moment. So if you are in the Northwest, you're very likely to go to a lot of study days in Altrincham. Doesn't matter, unfortunately, it won't matter if you're in a practice in Blackpool or Crewe. You will still have to go to Altrincham for your study days. So I just thought I'd let you know. Luckily, Sara, you got away with that, Sara. So why is the FD year good? And this is why I personally think it's great. Some of you may disagree, Sara may disagree. It's a really good starting salary. Not many graduates, if you can tell me a graduate that's on more money than that, it'll be very niche. And it's pretty generous in terms of the clinical work that a normal dentist does. To earn that money, you would still have to do quite a lot of clinical work. You get a good amount of holidays. You're employed. You don't have targets, which I'll go on to soon, which most general practitioners do. You're paid to learn. So when you go to a study day, you're actually physically being paid to be there, which I think I've told our scheme, Sara, a couple of times. And the other thing is that ESs and dental practices, they go through such a tough selection process. It's so hard. I absolutely hate it. You get random people coming in, checking clinical notes. They go round, checking the practice. And I personally feel like it's worse than a CQC inspection. So if you ever heard the hospital staff go on about CQC inspections, well, I think it's worse than that. So you're very, very likely to get a good foundation practice because of the rigmarole the dentists go through. You'll start to know what you like about dentistry and what you don't really enjoy. And that might be hard at the moment because through uni, I know I didn't know if I really liked a particular aspect of dentistry. I didn't really know. And I think the FD year really opened that up for me. You'll increase your clinical experience a lot, dramatically, most probably within the first couple of weeks. And you receive a lot of one-to-one support. And I don't feel a lot of professions have that. I think dentistry is so lucky that way. And the FD year definitely provides that. And I think there's a lot less bureaucracy in general, even though there's a lot of issues with applications. But when you get there, it shouldn't be full of red tape, which maybe you find in the hospital. I can't speak for Manchester, but I can speak for Liverpool Uni, and there's a lot of red tape there that I feel like reduces the progression of the students. So why FDs may not like it? So there's a portfolio that has to be done. HE like a lot of reflection. So if you're not one to reflect, you've got to do it. You've technically got to pass the year, but it's not like being in uni in any way, shape or form, in my opinion. Some FDs sometimes say, well, I can't earn more money because I want to do something else. And you're not really supposed to be earning any more money during the FD year. You're not supposed to do any private dentistry in that time. And obviously it's a massive adjustment from uni. Sort of the support, the bubble. You might not be with, your group of friends that you've been with for 5 years, and then just life in general. You're now going to be in working life, and this is a massive adjustment when you've been in uni for 5 years. I was in uni for 7 years, so it was a big adjustment going from uni to working life. And also right now, I appreciate that the application process is a little bit of a hassle. So that's my negatives anyway. So what the FD year isn't about, and I'm saying it like this way because I think people get a little bit confused about what it is and what it isn't. it's not about your ES coming in at every beck and call. They have a normal list of patients. They are there to support you, but they're not there to hold your hand every day and every second. It's not really about to teach you what you should already know. You've been to uni for 5 years, so that expectation should be quite high. You're not going to have the same experience as your mates. You'll be in totally different practices, different personalities, different surgeries. Size of the practice will differ. Loads of different things will be different, and some people get a bit hung up on that. You're not going to learn how to carry out full mouth rehab. You're not going to be doing all these, high-end monitor sant things. You're just not. It's not about that. It's not what the FTE is about. It's not about social media. It's not about moaning about how you don't earn enough money compared to other dentists, which I usually get from some FDs saying, I don't earn enough money right now. And also, it's not, you won't always know what you're going to do long term after the FD year. It's not a given. It wasn't for me when I finished my FD. I didn't really know what I was going to do. So that's not what the FD is about. It's really about understanding primary care, understanding the NHS system, and increasing the amount of clinical work you do for general clinical experience. I'll touch on this very quickly, but that's what the portfolio is of. So you have things called case discussions where you discuss the cases with your ES. Like I said, loads of reflections. You have to do an audit. You have weekly tutorials with your ES. And you have to do some case presentations. And then other sort of what we call work-based assessments, which is what an ADEPT is really, where you're observed and your ES make sure that you're competent in that particular area. And obviously study days as well. So the differences when you're coming from a dental hospital is that I feel a lot of the courses are dictated by the setting that you're in. So I went to UCLan, and that is not a hospital-based course. And I know working in Liverpool, I can't speak for Manchester, but working at Liverpool, I know that there's general sort of politics within the hospital and the trust that sort of dictate how you learn. And I think that is the case everywhere. And dental practices, once you're in a dental practice, they're their own entity, and they can interpret guidelines and policies how they see fit to an extent. You might not agree with them, but they may not work a particular way. They may not go through a guideline that you're used to at Manchester, and that's something hard to consider and is a big change. But you just have to accept that that's how our job is. Guidelines and it's just sort of the same thing. Guidelines, textbook theory might not be appropriate. We don't all have the same equipment. We don't all have the same materials. We don't work all in the same way. So ES is I might have gone to UCLan. My FD right now went to Liverpool, and there's certain things that I didn't learn that way. I didn't know how to do that procedure. So there's sort of a give and take with that approach when you come to be an FD. And also the biggest thing is that the NHS system is not particularly flexible to suit what you've been taught either. And that's a big learning step when you come to FD. And one example there is perio treatment plans don't last forever because the NHS system is very binary. You either finish a course of treatment and you finish a treatment plan, or you don't. So there's none of this open-ended perio problem with patients, and some FDs find that difficult. One thing as well is that, I know for Liverpool, tell me if I'm wrong, but usually dental students, your patients are triaged and are given to you what's appropriate for you. Well, when you go into FD, that doesn't happen. You will see whatever comes through the door, and you'll have to treatment plan whatever comes through the door. So, and there's not an expectation in our practice. We don't really say this dentist is training. We don't really say that because that's why they changed the terminology from vocational trainee to foundation dentist. They didn't want your title to have trainee in it. So in practice, I never say you're going to see an FD. The patients don't know what that means. They just think you're a dentist and that's it. They won't be sort of empathetic to you being new. So that's quite a big step going into FD. And at the end of the day, you will have a GDC number and you are independent. So your decisions are your own still at the end of the day. You'll be well supported, but you will be independent. So my personal tips is I don't think you should worry too much. Even though Sara was trying to get you to the best ranking as you can be, my opinion is not to worry too much, because at the end of the day, if you pass your exams, it'd be very unusual for you not to do FD. And so my sort of spin on it is don't put too much pressure on if you're in 5th year. Don't put that pressure on yourself. Like I said before, don't assume a scheme stays the same, or it's necessarily anything to do with the geography. I was once when I was an FD, I was on the Aintree scheme. So if you know where Aintree is, I was on the Aintree scheme, but my practice is in the Wirral, so I have nothing to do with the name of the scheme. So that's just the way it is. When you come to, I know it's only October, but if you know where you want to go, and you get to that point and you know what scheme you're in, then try and contact the practice, just find out more about it. It's fine. Ring them up, send them an email, do what you want. If you're really set on a particular area of dentistry, and I don't know how you would know that now, but some people do, some people just know what they want to do. So if you, for example, you want to be an oral surgeon, find someone who does a lot of oral surgery. That's just sort of common sense. And think about your practice and the commuting distance. And just remember that there'll be a lot of differences between them. Like I said before, size, specialities, it won't all be the same. And like I said before, just think about your study day travel as well. It's less than, over the year, it averages at less than 1 a week, but it might be something you need to consider. So I will stop talking, and I don't know if you want to carry on, Sara, and then we take questions, or I'll take questions now for the bit that I did.
Yeah, just to carry on from what you were saying, in terms of my experience, I think in the first 5 weeks of working, it's definitely a big shock to the system. Not in terms of like the transition, but honestly, you're just so tired all the time. But what Jay was saying about choose your practice carefully, I'd definitely say, yeah, be cheeky if you can and look for the things that you're suited to. So for me, I'm in a really big practice. It's 15 surgeries and there's 2 other FDs as well. So for me, that was what I really wanted. Like, I didn't want to go anywhere that was quiet and kind of feel a bit isolated. And it's helped with the transition from uni as well. I think I still kind of feel like I've got a good support system, and it's not just, okay, you're on your own. What is weird is making decisions for yourself. I think in the first 2 weeks, you're just thinking like, nope, I want my AS to check everything. But obviously that's not possible or realistic. But it is quite nice once you find your feet to think, yeah, this patient's come in, they're in pain. It's not like uni where you can only drill at certain times, or you can't take a tooth out because you're on restorative clinic, so you need to do anything but that. You can kind of think a bit more on your feet, and you feel like you're actually making a good difference. So it's nice. But yeah, choose carefully when you can.
There we go. There's a question. Can you explain again what schemes are? So schemes are just, a scheme is just how you're grouped in. You're just put into groups. So it doesn't matter what area you go to. If you're in the Northwest or if you're in London, you will be in a particular scheme. So, and it's usually just all to do with study days and who your TPD is. So so my job is just to sort of externally support the FDs, and sort of I direct the study day program. So that's we put FDs into schemes. So it's more of a logistical thing actually. So it doesn't matter about the schemes per se, but like Sara just said, when you come to choose and you come to put your rankings of where you want to go, the schemes will be there to rank. Does that make sense? Have I made that clear? Sorry. Is that okay?
We've got another question. How would you find out what practices are more specialised in certain areas? Is it a case of calling them up?
I think there's something called Google. I would just put it in Google. The practices will be listed. They will be listed, so you'll be able to literally put them into Google. So the ones who are specialised are very, very likely to have, websites. They'll want to advertise that, so it won't be a secret. Sara, I think you were gonna.
Yeah, you get
something.
given a little biography each ES and the practice as well once it does come to the point of ranking. Some ESs make more effort with like selling themselves and the practice, so you can base a lot off there and maybe contact the current FDs as well, which is always a good sign. We got told not to contact the practices because I think they started getting harassed when the practices came out. But there's a lot of ways.
Oh, really?
Yeah.
Is that what you got told?
From HE, yeah, we all got an email.
Just ignore HE, just to contact them anyway. I'm saying this independently, remember. Yeah, because I mean, years ago, sorry to harp on, but when I applied, I literally physically went to every practice on my scheme because I wanted to know. I needed to know where I was going. That's just me personally. Some people won't care. But I wouldn't be worried. I don't know what, I didn't realize, I honestly didn't know HE put that message out. I didn't know that. But in the meanwhile, just ask them, just send them an email. Is there a map of last year's DFT places? So yes, I've just given it to you. I mean, I can try and send you a specific map or a list, but the only problem is when people ask this, you've got to know that they can change. So that's why HE aren't very keen on sending maps out for that reason. That's why they don't want to share who was there last year. Does that make sense? Because they don't want to get your hopes up, because you may put a scheme really high, and by chance that practice either is not in that scheme or isn't even an option anymore. So that's what they don't want you to be disappointed. I think they're trying to do so you're not disappointed. And that's what I'm trying to say. It's sort of, I personally just would not go off the previous schemes. I just wouldn't. I knew one person personally, and they were riding on a practice in St. Helens, and that practice was stopped being an ES practice, and they were like, I wouldn't have chose this. They put the practice so highly into their mind that they were like, I wouldn't have chose that scheme if I would have known they were pulling out. But you won't know until you get your rankings. So it's really a gamble, basically. It's pretty much a gamble. I mean, for the likes of Sara's practice, where there's multiple FDs in one practice, that's a bit different, because some FD practices do have more than one ES or one FD. So that maybe is more of a, a less of a risk, but it's just a risk that you're going to take. But I just personally wouldn't get bogged down with rankings and schemes unless it's geography. It's really geography. If you're accepting you're going to be in the Northwest, for example, then you just sort of have to accept that that's where you could be, and that's how widespread it is. Is that all right? Anything else?
Got quite a few more questions come in.
Okay.
So the next one is, does everyone have the same content over the year for study days?
Yes.
Okay, that was short and sweet. And a few people are asking about whether they will have access to the recording. Yes, it should be up on our YouTube, hopefully by the end of this week.
The reason for the same program is because it was something that was historically complained about. So there's different schemes historically had different study days, and this was something that previous FDs complained about, and so now the whole program is centralized, so everyone has the same study day. There's the odd caveat where maybe we need to I don't know, someone's talking about endo and we can't have the same speaker, but generally it's all the same.
Fantastic. Someone's asking, are schemes and deaneries the same?
No. So deaneries are the areas. So deaneries don't really exist. Sorry, it's just HE areas. So deaneries used to exist and they sort of don't now. So basically there's 7, let's call them deaneries just so we don't get confused. So there's 7 deaneries in England. So the Northwest is one of them. And I'd have to find out the rest of them. I don't want to give you the wrong information. I think there's the Northwest, the Northeast, the Midlands. Help me out. I think the Southwest, Southeast, Wales, and maybe somewhere else. So that's the area. So it's just more regional areas. That's, I would say. So the deaneries are regional areas. The schemes are more localized to the region. So for example, the Northwest has Cheshire and Mersey, South Cumbrian Lancs, North Manchester, South Manchester. So that's what the schemes are. But again, I'm trying to really emphasize that the geographical relation may not be so strong. That's, I think the message needs to be very clear. It isn't just for example, I've said to my boss that the schemes in the Northwest should just be named A, B, C, D, and E. That's my opinion, because they vary so much. So you would just have to accept it in the Northwest, but they try their best, and I'm saying they try to put them into geographical schemes. So Cheshire and Mersey, they try and put the practice in Cheshire and Mersey. But like I was saying, my scheme with Sara's in, it's so widespread, they sometimes have to cherry pick which is going. So for example, Southport, there's a practice in Southport that's been in Cheshire and Mersey, but is now in my scheme in South Cumbrian Lancs. Yeah, so it's, I think it's a really bad message for HE to try and make out it's all geographically related when it's not. It's not like that. I think it's best to accept it's not, and anything that's better than that, you're winning.
We have quite a few more questions, but we're going to save them for after Sara's spoken.
Okay, cool.
So people can find out more about the SJT.
Perfect. Shall I share my screen now for a bit, Jay?
Of course.
Okay. Can you all see that? Perfect. So before I start, just another disclaimer. I'm not an expert in SJT, and honestly, your rank isn't the most important thing in the world. As Jay said, it's just not worth consuming yourself over. In fifth year, your biggest priority is just getting your finals out the way and meeting your clinical quotas. So worry a lot more about that. Once your SJT is done, I know it's not easy, but you just need to forget about it, because you don't find out your rank until, I think it was June for us. So it was at least 8 months afterwards. So yeah, put it to the back of your mind and don't over worry it. For you guys, obviously it is 100% of your rank, and there's two main types of questions. So you've got your ranking based questions and you've got your multiple choice based. You have 105 minutes for 56 questions, and you'll do it at the Pearson VUE test centres. So it's where you did your UK CAT, your provisional, all of that. I'm not sure if your slots have opened yet for booking, but if they haven't already, then on the day where you get an email, make sure you try and book it as soon as possible, because the slots go really, really quickly. Ours opened at like 6:30 a.m. It was a really random time, and then everyone rushed to try and book the slots, which weren't first thing in the morning and weren't last thing. And then when you're in a big city like Manchester, you might be traveling a little bit to get to your test centre. So what I'd say is just be on it with when you get that email, and try and book it at a time that you know suits you. So I'm not a morning person. I really didn't want the 7:20 a.m. slot, which I know some people did end up with. I also didn't want the slot right at the end of the day, because your brain's just tired and you just kind of sat twiddling your thumbs waiting for the time to come. So yeah, just choose for a time that'll suit you best. During the actual exam, so you've got your flag for review button, which is in the top right of the screen usually. It's the same as what you had for your UK CAT. What I would say is don't flag for review until you've actually attempted the question, just in case you do run out of time. The worst thing you can do is leave it blank completely, because you're just losing marks for no reason. There is no negative marking as well, which is another reason for just not leaving anything blank. The worst you can happen is you get maybe 4 marks or maybe no marks, which is quite hard to get. But yeah, just make sure you do finish on time. So I think it works out to about 1 minute 52 per question, which is just ridiculous. And everyone on these courses is like, yeah, 1 minute 52.5 seconds or something like that. Just keep an eye on the time generally. It is quite hard to concentrate for that long, and decision fatigue's real. Like, you just get so tired. I remember when it was mine as well, there was other people who are doing different exams at the same time as you, so they're in and out a lot quicker, and it's so distracting. They give you like overhead headphones to wear during the exam, so if you are getting distracted and you think that will help, then put them on. There's nothing wrong with that. I did. So general tips to do well, I mean, I don't want to state the obvious, but I probably will. Practice really does help. So I know a lot of people are like, yeah, you can't prepare for your SJT. I think you can. What I kind of did was small but regular doses. So I think once it got to like the 4 weeks before mark, me and my friends would kind of make sure we were just doing a very small amount of it every day just to keep it ticking over.
Right, and she got Preston, so.
It is something that you will practice alone, because obviously in the test centre you are alone. But what we found really, really helped was to mark the answers with your friends. So we'd all do the same set of like 20 questions, and then we'd mark them and talk through them. So if anyone got anything majorly different, it was kind of like a debate of like, oh, I put this because I thought this. And then the other person would be like, oh, but what about this? And it's just good to have that discussion, because you can kind of appreciate where someone else is coming from and kind of open your mind a little bit. I think when you are practicing with friends as well, you'll tend to find that like there might be one person in the group who's consistently getting them right. So it helps to kind of start training your brain to think the same way as them. When we were practicing, honestly, I wasn't getting everything right at all. Sometimes I'd put things which I'm quite sure would have been a dangerous answer, but it will just come with time. So don't worry about it too much and don't overstress it. I found that we did all the unofficial questions that we did have. So I know there's courses that give out their own mock papers. There's some from random books. There's the official ones that are released by Copend. Just do all of them if you do have the time. There's definitely no harm in it. But bear in mind when you're doing some of the unofficial ones that the mark schemes might not be spot on. There might be things that you just don't agree with, and that's completely fine. Just take some of them with a pinch of salt. As it gets a bit closer to the date of your actual SJT, so maybe a week before, I'd say try and do some full-time practices. So sit through a full paper and do it under time conditions. It is quite different to doing like 10 questions at a time, because when you sat for that long, your brain does just get a bit tired. So I think it's quite useful to do it in kind of exam conditions, just so you can start getting used to that. Something that other people were doing, I didn't need to do this because mine was at like midday or something, is if you do end up with a slot at like 8 a.m, then try and wake up early the week before it and do some questions at that same time. Just because your brain can be in a bit of shock sometimes when you're trying to put it to work that early when you're just not used to it. So I think if you kind of start doing that brain training a little bit in advance, then it probably will help. You probably heard this one before, but when you're answering questions, do it how you should react, not necessarily how you would. They want you to be a bit of a snake sometimes. They want you to be the biggest goody two shoes. Obviously, you've just got to be that for this test. It's not always the most realistic answer, but just think textbook. I know you've heard this 100 times before again, but just know your GDC principles. Read over them. You don't need to study them or know them off by heart or anything like that. It just helps when you're sometimes looking at a question, you're thinking, oh, I don't know which way to go. If you can link the answers to what the GDC principles are, then it kind of gives you a bit of a guiding point, I think. I'll run through a few of them afterwards, but yeah, just give it a read, really. Another thing that I found when I was practicing was just read the question carefully, because a lot of them will kind of tell you in the sentence whether you've just started FD, whether you're 6 months in, and your experience and how you'd handle a situation changes a lot depending on which point you're at. If you have just started, then you're not going to be taking as much responsibility as you would maybe at the end of your FD year. So just read the question carefully, because it does definitely guide you with what it's looking for. Some of the options you'll get will just be stupid. They'll say like ignore something that's a major red flag. Some won't be as obvious, so it'd be kind of like dismissing something, but that's rarely ever a good option. To do nothing is obviously less than ideal, so just bear that in mind. And some of them will be kind of seeking advice. So this is what I think is a bit of a soft option. So it's not ideal and it's not the worst thing to do in the world. Usually comes somewhere in between, but just think, yeah, you might be seeking advice, but are you actually doing anything with it? So just a general tip is try and be active in what responses you're choosing. So examples of being active is something that's going to secure patient safety. So say you've got a really rowdy patient in the waiting room who's kicking off, are you going to just turn your back and close the door, or are you going to actively deal with the situation? Seeking advice where it's appropriate. So I know I just said it's a soft option, sometimes comes in the middle. It usually does, but if you're seeking the advice and acting on the advice, then that's still being active. Don't deflect responsibility. So don't just think, yeah, I'm only the FD, so I don't need to do anything, it's not my problem. Think of how you can maybe put the responsibility onto the right person, or kind of guide it down that route instead of just turning the door on it completely. This one's obvious, but don't just do nothing. Don't just wait and see. Waiting and seeing is quite a common one that did come up for us. Obviously, if a problem's already come up, then you can't just wait to hope that it figures itself out, because it's telling you need to do something about it. And don't just seek advice when you're in indemnity. So again, it links back to what I already said. Indemnity is kind of a wishy-washy answer in terms of SJT, because it's all good and well seeking the advice from them, but they aren't in practice. They aren't directly kind of watching over you, anything like that. They'll give you the advice, but it's up to you whether you're actually going to act on it. And be direct. So when you're choosing your answers, just think, is this actually a solution, or is it just making me feel like I've done something, but really I'm just beating around the bush? So linking back to what I just said about indemnity, don't just take advice. They're not a pointless organisation, but sometimes they'll kind of tell you about like a patient complaint, and then they'll throw in the CQC as an answer. CQC are way more to do with like health and safety and that kind of thing. So just think, is it really relevant, or are they just trying to throw me off the mark a bit? Don't take on too much responsibility. So remember, you are the FD in the situation, so you don't need to be the hero that's solving everything. There will be things that are way out of your scope. So it's just important to make sure the right person's dealing with it, rather than you kind of trying to figure everything out on your own. Don't cover for other FDs. So this is quite a common one that comes up. So you might have a friend who is missing a study day and they want you to sign them in, or something like that. What you might do in real life is a different story, but in this, just don't cover for anyone else. And don't apologise without actually getting to the root of the problem. So you might have a patient who is kicking off about something. Yeah, you can apologise all you want, but what's that really going to achieve if you're not proactively doing something to change the situation? So again, just bear that in mind. So linking back to what I was saying about working within groups, so that came up in question for us was, it's not your role to break really bad news. That's beyond what you see day-to-day practice. So you might have a patient, and I think this was a question we got. So you had a patient who had like a white patch, which looks like it could be cancer, and they're really worried, you're really worried. What do you do? So obviously don't lie to the patient and tell them that it's all fine. Also, don't tell them like, yeah, it's cancer and I'm going to refer you to hospital, because you can't be sure about your diagnosis. You're not an oral medicine specialist. But just be honest. So tell them that you're referring them, why you're referring them. And yeah, just play it safe with these kind of things. There's quite a few situations as well. So they'll let you know that it's your first time doing a certain procedure. So for example, you've never done a post-crown before, and now you find that you're doing it in your next appointment. If it does specifically say that it's your first time doing something, then always err on the side of caution. So get your ES in, do something proactive, like ask for your tutorial that week to be on post crowns. These are quite common things that they definitely like, so just bear that in mind. Don't work outside of your normal hours. So again, this is quite a common scenario that came up in questions. You might be, someone else is running really late in practice, and you've got an option of you stay late and help them to catch up. Or your principal might say, look, we're not going to meet our UDA targets. Can you stay late or do an extra day? Even though, yeah, you think you're going to be the nice person to be like, yeah, I'll do it. In SJT questions, they just don't like that answer. Don't do too much, because they care about burnout, they care about patient safety, and all of it hand in hand doesn't go too well. I don't know if you know, but so what I was told by an ex-TPD was all the scenarios are real ones that like ESs have submitted and said, yeah, this happened to us in practice, and they go and write it as a scenario. So they're all really realistic. And I know everyone kind of says like, don't overthink your answers, but sometimes you really do need to overthink, because they're quite tricky in like the sense that there's only a couple words difference between the answer of A and the answer of B, but it makes all the difference. So if you're looking at one and you're thinking these sound exactly the same, definitely like think twice, think 3 times about it, because they will be trying to make a point, and it's just a matter of like getting used to what they might be trying to hint at you. You can't completely support another FD or colleague in practice when you're in your foundation year. So you might be given a scenario where you've got a struggling FD who's also in your practice, or you've got someone on your scheme who's struggling to cope. You can give them advice, you can signpost them where to go, but it's not your job to kind of look and sort out their issues. And another one that came up for us was medical emergency related. So just make sure you're not handling it completely by yourself, because as an FD, you wouldn't be doing that. Something that helps just to have a really general understanding to like get your way around these questions is know the key people and know how to escalate and who to escalate to. So it links a lot with what Jay was just saying. So you've got your ES, who's your person in practice. They're there to support you a lot more clinically. Obviously, they're not there to hold your hand, but they're kind of your go-to with any clinical worries, any patient worries, that kind of thing. You've then got your TPD, who's above your ES. So if you can't solve something in-house, but you've tried to talk to your ES and it's not getting anywhere, then your TPD will be the person to go to with that. If it's something that you're just not comfortable telling your ES, then again, TPD is a good place to go with that. A lot of the time, don't just jump straight to your TPD in these questions. They do like you to try and solve things in-house where possible, and then escalate if that can't be solved. Above your TPD, you've got your associate dean. So that's kind of your TPD's boss as such. It's quite rare that you need to go to your associate dean. It's got to be something that's quite a serious problem. Again, you try and solve it with your ES and your TPD first. And if that can't be solved, then your associate dean's the next person to go to after that. Your nurse, obviously, most of you know what the nurse's duties are, but just know that it's not your full responsibility to be looking after your nurse as an FD. Obviously, you're the person that is working with them quite closely, so you should know something's up and things like that. But if they confide in you and tell you that they've got this serious problem, that they can't pay their GDC registration, because that was a question for us, then you need to escalate that instead of you trying to keep the secret or help them solve it. You've then got your receptionist, who's front of house dealing with day-to-day patient queries. You've got your practice manager, so they deal with the more admin side of things, so maybe your rota, your hours. If you've got an issue with your nurse, then you might be going to your practice manager rather than your ES, because it's staff management rather than a clinical issue. You've got the principal dentist, who's quite often the person who owns the practice. So them and the practice manager go quite closely hand in hand. But again, if it's slightly more clinical, then tends to be a principal dentist. You've got CQC, so they're kind of health and safety related. You don't do too much with them, but it's, mostly health and safety. GDC, we all know about the GDC. You only really go to them if it is quite severe. So again, you definitely try and solve things in-house before you go to them, but can be a last resort sometimes. You've got the BDA and you've got your indemnity. So these two are good to get advice from, especially if it's like a case-based worry that you've got and your ES can't help with it, but they tend to be quite in the middle. So they're not definitive answers like, yep, I'm going to go to my indemnity, but they're also not the worst thing in the world. It's good to gather information, but again, just think, is it actually being active whilst I'm talking to the BDA or my indemnity? I'm not going to bore you to death with talking through GDC standards, but what I will say is the main one that links to almost every question is just make sure you're putting patients' best interest first. This standard, I would say in terms of SJT, does come above all the other ones. If anything's going to be causing harm, then you need to do something about it quickly. But just remember to listen, be honest, all the usual stuff. Making sure you're communicating effectively. So again, it's a bit of a given. Just make sure that patients always have the information in a way that they can understand. There's some questions where the patient can't understand English. So just think about, is your consent going to be valid? What can I do to aid the situation? Can I get an interpreter? Can someone else speak the language? Don't just run with it. Gaining valid consent. So make sure you give all the treatment options, all the involved costs. Make sure it's all in your notes, but I'll talk a bit about that afterwards. Maintain and protect patients' information. So this can come up in a sense where sometimes you might have a question where it's like the partner is calling your reception and wanting to know details about where their partner is, how their treatment's going on, how long they're going to be, things like that. That one comes up quite a bit. So just bear in mind about how much you can share. Yeah, just think about that stuff. Complaints procedure. It has to be displayed where patients can see, needs to be simple, easy to follow, in plain English. Each practice does have a written log of complaints and it needs to be resolved efficiently and effectively. Making sure you're working within your knowledge and skills. So remember that you are an FD, so you're not a hero. You're not meant to be doing surgicals by yourself. You're not meant to be doing full mouth rehabs. You just need to be working within your limits, and you are still a safe beginner. So just always bear that in mind. Making sure that all team members are also trained and qualified. So I think CPD, is everyone in the practice doing it? That kind of thing does come up. I won't read through the others because I'm sure you know them, but the second most common principle that links to a lot is raising concerns if patients are at risk. So there's a lot of scenarios where you have worries, but you're not sure if they're valid or not. If you are worried, then you're within your rights to raise a concern. It's not correct to be sitting on your worries in an SJT question. You need to actively do something about them. Quick one about consent. I won't bore you with it, but 3 elements of consent. It needs to be voluntary, it needs to be informed, and it needs to be given by someone who has capacity. There will be some questions which involve children, so just know your laws and stuff that are in the PEDS manual if you're at Manchester, about who has parental responsibility, who can consent. Obviously consent can be withdrawn at any point, so just bear that in mind. A big one is that your notes do need to be contemporaneous, concise and complete. So this means you need to be writing your notes at the same time as doing the appointment or straight after it. There is questions which are like, you're really tired, you're not feeling well. It doesn't matter in an SJT question, you need to get your notes done because it's part of the law or whatever, that they need to be kind of in real time. Another one that crops up sometimes is disclosing your notes. So main ones in the SJT question, you can only disclose your notes if it's because of a court order or to protect the public. So if you've got, I don't know, say police who are doing an investigation and want access to your notes, do they have a court order, or is it going to cause immediate harm if you don't give access? Just be careful about sharing your notes left, right and centre. Common scenario again is when something bad happens. So there was some for us where I think so the question was something like, you're the dentist, there was 2 kids who were waiting in the waiting room and they were twins, and you've got the wrong twin in and you've started doing treatment on them. So the first thing, which is just in all these scenarios where something bad does happen, is tell the patients what's happened. Obviously this was a child scenario, to tell the parents. You need to apologise, you need to seek advice where needed, so get your ES if that's what's appropriate, or maybe speak to your indemnity, depends on if it's like an immediate need advice or a long-term need advice. Be honest with the patients to tell them the effects of what's happened, so they need to know short-term effects, long-term effects, and offer a solution. So again with this, if the option was just to apologise to the patient, just think, okay, I'm apologising, but am I fixing what I've actually done? You wouldn't be. If it's something that's a bit more logical, so it's dealing with the short term, the medium and the long term, then that's going to be a better answer. So just think about what's a bit more holistic in that scenario. Some recurring themes of questions which you'll notice as you do more practice do tend to repeat themselves a bit. So if you've got someone in your practice who isn't on the GDC register, then that is illegal, it needs immediate attention. You might have a nurse who's saying they can't afford it, they'll get back on it in the next month once they've been paid. That's not okay. Missing study days, Jay will tell you this, it's just a cardinal sin in SJT and in real life. Just don't miss your study days and you'll have an easier life, and don't cover for anyone else who's missing them. Be a safe beginner, like I already said, so just ask for help where needed. Don't just struggle in silence, because you're probably going to do harm by doing that. If you've got options which say ignore, then that is going to be quite low down. I already said the suspicious lesions questions. Don't diagnose, but also don't lie to the patient. Think 2-week referrals and all that kind of thing. Just a general one, you don't need too much clinical knowledge for SJT. I know a lot of courses will kind of bog you down with like SDSEP guidelines and things like that. They don't need that much detail, so you don't need to worry about it. Sometimes you might have a patient who comes in drunk. Just as a general rule, don't carry out the treatment if they are drunk. Another one which comes up a lot, so you'll have the patients who are complaining and they're talking about the dentist that they had previously, saying they did this, and they're not happy with it. General rule of thumb, just don't talk bad of the previous dentist. Explain that you weren't there, you can't comment on what happened, but you'll do everything you can to get them sorted. Just keep it general, but also don't lie to the patient. I already touched on this one. Finish notes on the same day. Never wait, because they need to be contemporaneous. Has anyone got any questions at this point, just before? I've got like 3 example questions and then I'm nearly at the end of this.
We've got quite a few questions that have come in.
Yeah,
so
good.
The first one is, how do you identify the worst and best options for ranking questions?
So worst and best are generally the most obvious ones. So worst is just doing something that's going to actively cause harm to the patient. So that's always going to come last. Best is an answer which is like thinking about short term, medium and long term. It's quite holistic. So it's not just kind of seeking advice and leaving it at that. It might be seeking advice, explain to the patient what happened and booking them in for a review appointment. That's an example. But they do tend to jump out at you a lot easier than the other ones.
Fab. The next one is, how do you utilize the whiteboard?
So I know a lot of courses will tell you use the whiteboard, do this, do that. I didn't use mine until I think I came back to the questions that I'd already flagged for review, and then there was maybe 1 or 2 that I was really stuck with. And to be honest, I still didn't use the whiteboard, because courses will tell you, all right, on the whiteboard, list the principles of the GDC and tick and cross which ones apply to which just isn't realistic when you're in that scenario. I think for certain people, if you learn that way, then maybe a couple ticks and boxes and all that kind of thing might help on the whiteboard, but generally I didn't think it was that useful.
Okay. And what should you do on the day of the exam? I know you touched on this, but do you have any more tips?
On the day of the exam, just take it really easy. You need to keep your mind clear. So don't try and like cram, because you just can't cram for SJT. It's just stupid. Go for a walk, get a coffee. That's what I did. And then I think I went with my friends, which also started stressing me out, because all my friends kept talking about like random little things about SJT, which just wasn't going to achieve anything literally 10 minutes before you're walking in. So I think on the day, just take it easy, make sure you get a good night's sleep, make sure you've had breakfast, had lunch, that kind of thing, nothing too heavy, but just try not to stress. I know that's easy to say.
Well, and how many practice questions should everyone be doing, / how often?
So I would say try and maybe start off with just doing 20 minutes or half an hour a day when you're maybe like a month before your SJT date. As it gets closer, so maybe 2 weeks before, a week before, then start trying to do full mock papers under timed conditions, so you're getting used to kind of how quickly it needs to be working. But it's not something that you need to overdo. I did kind of like, and my friends actually, we did kind of all the questions that we had. So we had mock papers from a couple of different courses. We had the white DTC book, DCT, that one. We had the official ones which Copden release. What I'd say about the official ones is they're definitely the most accurate in terms of what it was like really on the day. So I did the Copden questions when I first started my revision, then I left them completely and I did them again just before the exam, maybe 2-3 days before it, just so I could see how I'd progressed, if I'd improved or not, but also just to kind of keep it realistic with what I was expecting on the day.
Fantastic. And did you do any courses yourself?
Yeah, I did one. I didn't recommend it. It was a big fat waste of money. They'll kind of sit and talk to you about like GDC principles 3 hours to make you feel like you've got some value for your money. And this is going on YouTube, so I'm going to stop talking.
Fab. One is about the questions itself. So in what situations is it acceptable to stay late or do extra hours?
So staying late, if you need to write your notes, then you do need to stay late because you can't leave that for the next day. You might have a one-off where you're helping a colleague with them running behind, again, just a one-off. If there's a question where they're making it clear that it's a recurring theme, you're staying late all the time and you're getting burnt out, then you need to proactively change that. It's not going to be something that they want you to carry on doing.
Great. And you touched on a few resources, but is there any other courses, books, resources that you could recommend?
Off the top of my head, I'm struggling to think, but what I can do is anything that I've still got saved on my laptop, I'll send over to you guys at the end to distribute as you want.
Thank you. I think that's all the questions just for the time being. We do have a few more, but I'll let you continue speaking and then we can have some more questions afterwards.
Perfect. I don't have that much more. So ranking questions, I think I already said they're 20 marks. So as long as you get the first and the last one right, you've automatically got 16 marks. So give them some thought. Even if you're in a complete panic, I don't think it's possible to get less than 8 marks statistically. So like I said, just don't leave anything blank, just put something somewhere. Remember with ranking questions that each option is exclusive from the next. So A doesn't link to B and B doesn't link to C. They're all individual options by themselves. And as a general rule of thumb, it doesn't always work. But what I did was did the best one first, I did the worst one second, and then 2, 4, and 3 was just whatever I was left with, because it was always somewhere like a little bit shaky, which wasn't horrendous, but it also wasn't the best thing to do. So left that one to last. Okay, so I've got an example question there. Shall I give it 2? And if everyone just wants to put their answer in the chat box, then I'll tell you the answer in 2 minutes. Oops. Oh, damn it. I think I'm stuck. Hang on. Is that enough time? Does everyone need any longer? Because I've only got one answer that I can actually see.
Yeah, I think that should be enough time.
Okay, so the answer for this one was B, E, D, A, C. From the one answer I've got, that was correct. So just to run through it, B would be ideal because you're completing the notes, which we already said do need to be done on the same day. But anything non-urgent, you're going to get done, but it doesn't have to be straight away, which is fine. That's not a problem. Still putting yourself first. The worst one would be C, because you're taking the notes home and finishing them later on. You can't really take patient information home in most cases. You do need to be doing it on the spot, which is why that's the worst one. Second best would be E. So you're again getting your notes done at the same time and you're being proactive, so a colleague can help you with your other tasks. But again, your notes are your priority. Second worst was A. So you are getting your notes done, but obviously you're being dishonest by calling in sick. So it's not as horrendous as not doing the notes at all, but you're still being dishonest. And then in the middle was D. So it's a bit wishy-washy, you're rushing, but you are getting it done. Obviously, things can go wrong when you're rushing, which isn't ideal, which is why it's somewhere in the middle.
So we had a quick question. Why is E worse than B?
E was worse than B. Read the notes. So B was best because you're getting the notes done and I get what you're saying, but I think it's still kind of, you're an FD and you're responsible for yourself. So if you can take care of things and prioritize in the right order, then you'll be all right. Obviously the tasks aren't that urgent, so you don't really need to get a colleague involved, and it is still your responsibility, which is why it comes somewhere there.
And someone else has just said, when can you ask colleagues for help? And when do you have to take responsibility and do things on your own?
It's difficult to kind of give just an answer without knowing the scenario. Ask colleagues for help is never a bad thing, but it's just a matter of, is something else better? The order was B, E, D, A, C. Yeah, I think
they might be in a situation where you get a colleague to help, but say maybe, you know, you're running behind because there's been a medical emergency and there's a checkup waiting in the waiting room. Well, your colleague can see the checkup. There's no, you know, if the patient's happy. So I would say something on those lines. But like Sara said, I'd say that's hard to say without there being a situation. Be very specific.
Also, sorry, someone's asked, what was the name again of the white book that you used?
So it's, off the top of my head, it's the one that's sold by the dental training consultants. You know, Shavana and Andan, that company. It's their book and it comes up on Amazon.
Thank you.
We'll do 2 more minutes for this question. Most of you have probably already seen it, but yeah, 2 minutes. I think we're ready for the answer for this one. So the answer for this is B, D, A, C, E. This was a real past question. So I think a current TPD is called Mike Stoker. He came in when we were in 5th year and put this question up. So you might find the answer a little bit confusing, but that was definitely the answer. So the best option for this was inform Lily that you've noticed that she's not been herself recently. The worst was E, so continue to observe Lily over the next few weeks and see if it improves, because that would just be passive. It's not doing anything to cause patient harm that she might make a mistake. Second best was suggest to Lily that you're concerned about her lack of concentration during appointments. So both B and D are quite direct, and it's actively doing something about it. It's not just beating around the bush and hoping that Lily will open up to you. The third answer would have been A. So ask Lily if she's currently got anything going on or whatever, just because, again, you are banking on Lily to open up to you. If she doesn't open up, then where do you go from there? And second to last would be C. So telling her that her lateness and behaviour is unprofessional. Obviously, it's quite horrible to talk to someone like that. You're telling her, but you're not kind of coming up with any solution. You're not trying to get to the bottom of the problem. And that's why that would be that order. Has anyone got any questions about that one?
Yes, so someone asked, why is it B and D in that order? Is D not more direct?
Yes, so it's kind of in the keyword, so it's inform versus suggest. Inform is quite direct, so you're doing something directly about the problem. If you're just suggesting it, then yeah, it sounds like a nicer way to talk to Lily, but like you're not really being honest and open with her, and your conversation could go a complete different way, and then you've not actually achieved anything with Lily. So that's the difference. It's very small, but this is what I mean about you have to overthink it with them, because it's literally the choice of one word which makes all the difference.
Someone also said that D seems unprofessional as it is during an appointment.
So it's not saying that you're talking to her during the actual appointment, it's saying that you're worried about her concentration during appointments. Does that make sense? So you're not suggesting this to Lily whilst you've got a patient in the chair. You're saying to Lily afterwards, Lily, I'm worried about what you're doing when we have got a patient in the chair.
Yeah, they said thank you.
No problem.
That seems like all the questions for the time being.
So last thing is the best of 3 questions. So these ones are 12 marks, and you're picking 3 answers which work together well. So don't pick answers which sound exactly the same and they're going to achieve exactly the same thing, because it's not doing anything new. Rule out some which are repetitive. So one might say apologise to the patient, and one might say apologise to the patient and offer them an appointment the next day. Obviously one is clearly better than the other one, so just get rid of the one which was doing a similar thing but not as good. Sometimes you might find that they kind of are written in a short-term, medium and long-term way. This isn't always the case with best of 3, and it does just take practice. Best of 3 I found quite hard, because sometimes 3 would work together really well, but then there'd be one really small annoying thing which would mean that a whole other 3 letters work together even better. So again, it's just a case of practicing as many as possible with them, really. And I've got one last question, which is an example of best of 3. So another 2 minutes and then we're done with my slides. Okay, the answer for this one was ACH. This is quite a nice, obvious one. So you're doing 3 things which aren't completely horrible to Ellie. So you're not just going to go and report her, because it could just be a genuine misunderstanding, but you're still being productive at the same time. So you're going to give her public records. Again, you're not doing anything wrong at all there. You're just being a nice person. You'd explain to her why it's unfair for her to be given the questions before, which is delving deep into kind of the root of the issue. And lastly, you'd explore with her why she is so worried. So again, you're just being a human, you're being productive, you're being active and you're being direct. You don't have to jump to kind of report her to the dental school or anything like that, because it can just be a genuine misunderstanding. Ellie might not know that what she's asking you is obviously wrong to do. But again, it is just a case of finding 3 that work together nicely and kind of picking according to that, really. And that is the end of my part.
Thank you so much. And that was really helpful for, I think, everyone here. Does anyone have any more questions for Sara? We have a few questions for Jay. Does anyone have any more for Sara? While those come in, I'll ask Jay the questions that we have. So the first one is, when do we find out the official list of schemes to rank?
It's a very good question. I think it's very late. I actually don't know. Sara, can you remember? I apologise. I'm not very good with actual application dates.
So I think I found out which scheme I was in at around 20th of June-ish. And then we got given the list of practices on our scheme. It got to about maybe 2nd week of July. So it is quite late. It's after your finals.
Yeah, I thought it was July. It is quite late. The only thing I would say is that this may change because there are changes to the way recruitment, and I think HE are going to try and put pressure onto the universities to, maybe for them to know if you've passed or not. Because the reason why it was so late this year was because there were a lot of universities not giving out, pass marks to students. So that means HE can't carry on. They have to all wait for all of the universities to give out the pass marks, basically. So that's why it was so late. And some I don't know where Manchester was up to with that, but some of them were very, very late. So there's a big message from Copdend basically saying to the universities there's going to have to be an agreement to which there's the latest date. I don't know when that is, but I've got a feeling you won't find out as late as Sara did. I can't say that for sure, but I do have a feeling it'll be earlier than July this time. Sorry, I can't answer that.
So the next question is, how long do you have to select your practices once they're released? And is preferencing for practice also to do with ranking?
In the Northwest, yes. But other areas can decide their own FD to ES ranking. So your scheme is off your ranking 100%, but your ES practice when you're in the local area is not. But at Northwest, it's off the ranking. So I think, if memory serves me right, Sara, did you get a week? Is it a week to decide?
Yeah, it's quite a quick turnaround, yeah.
Yeah, it's a week. So yeah, it's quick. But again, it may change.
So how many schemes can you apply for?
You can apply for all of them.
You need to rank all of them.
Yeah.
Rank some, yeah.
Yeah.
Great. So the next one is, how does a Northwest 2-year scheme work, and what sort of specialties or hospitals are usually included in this?
I know this was a question coming up, and I tried to message the TPD who's responsible, and unfortunately he didn't get back to me. I know. Oh, good.
My practice are on the 2-year scheme.
Oh, there you go. Sara can tell us.
So there's 3 of us all together. I'm on the 1-year schemes that I do 4 days of general dentistry. The other 2 girls, because where we work is also a tier 2 referral centre for minor oral surgery, so it's complex extractions. They'll do Monday and Tuesday seeing general dental patients, so your day-to-day stuff. And then Wednesday and Thursday, we have a consultant that works in the practice doing an oral surgery list. So they're with him 2 days a week, kind of assisting right now. And then they'll go and do their own within the next couple of weeks. So there's a couple that are oral surgery based, and I think a couple of them are more special care community dental services kind of thing. But that's the majority of them.
Yeah, that's basically, yeah. So this is sort of a work in progress as well. The 2-year schemes are becoming basically the agenda is eventually, is really they want longer FD placement so that you get to do FD and DCT at the same time. So come the current 5th year, come next summer, there may be more 2-year places available with different specialities, but it's an up and coming thing. It's very much in its infancy. So this is the first year that it's a concrete 2-year program, but previously it's been like they've been piloted. It's not been an official thing. So they are, I think they're pretty exciting things to do. I think it's, if you know that you want to do DCT now, you want to do it, then it's sort of a given to apply for it. And it's most probably quite nice to know that you're going to be quite secure for 2 years and you've got that support for 2 years. So it's definitely something to think about. But in terms of the specifics, it's all last minute, and it's very hard to, I'd have to have a whole day to explain why these things aren't so straightforward, because Sara's mentioned that in their practice, they're basically sharing the 2-year scheme, and they've got what we call a tier 2 service. So that means that the oral surgery is done within primary care. Other placements, other FDs will go to a dental practice and be with their normal ES, but other 2 days they'll go to a different place. So for example, a community centre or a hospital. So these things are very much based on commissioning, which you won't really know a lot about, but there's a lot of politics. There's got to be a spare chair. So it's not as simple as just a place is there, unfortunately. It's not so easy. So it's something that you can look out for, but you could maybe contact, if you're really interested and you want to maybe find more updated information, is contact me. I'm happy for to contact me to see if I can give you any more information as the year goes by.
Great. And the next question we have is, how often do you have contact with your ES?
Most probably every day. The educational supervisor is contracted to a minimum of 3 days in the practice. There will be the odd exceptions and caveats to that for different reasons. So there may be, but majority will work a minimum of 3 days. In terms of contact, well, it could be every hour. You could just be seeing each other for a chat, or I see my FD right now is literally in the surgery opposite me, so I routinely see him. But it will all vary, and this is where the expectations between the ES and the FD are. We try and cement that in the first couple of weeks in terms of what is the expectation, how are you going to communicate. For example, if I'm doing an RCT or a difficult extraction and the FD needs me to look at an X-ray and it's not impending and no one's going to die, then I can't go in at that moment in time. It's not appropriate. A lot of things can be left. If it's a situation where I have a difficult extraction and the FD's patient is having a medical emergency, I may just put my forceps down and go to surgery. So it's that type of approach, and every ES will be different in their, how they manage that, and very likely, definitely with Sara's practice, there'll be other dentists and other staff to help as well. So usually ES practices are usually, I would hope and say that they're very open, and more than just the ES is happy to help the FD, because we've all been there at the end of the day. So I would hope that the practice that we advocate it's not just about the ES and the FD, it's the whole team for support. So I can only assure you that, you'll be well supported, and also that's what I'm here for. And the whole structure is in place to ensure that the FD gets the support they need for the whole year. So there's a lot of support. I hope you agree, Sara.
No, there actually is. You're not left completely alone to just struggle in your own surgery. It doesn't work like that.
Great. And the next question is, at what stage in the application process do you apply for 2-year programs, i.e. when ranking your schemes? And would you find out what specialities are done there before you apply?
So you rank them at the same time as ranking all the other schemes. And the people who put it first this year had no idea what the actual like what was on offer, so they just went in blindly. In the Northwest, it literally covers the whole of the Northwest, so you have to be willing to be anywhere in it. But I think because this year it's a lot more established, they'll have a better idea of what it consists of.
Don't forget that if you get a 2-year place, and let's say, for example, you weren't too fussed on the speciality. I'm going to call it speciality because DCT isn't always so specific anyway. So if you think about the 2-year scheme, you do not then have to apply for DCT1 because you've got into the 2-year scheme. So that means if you're 2-year FD, you will have done DCT1, guaranteed to have done, well, I wouldn't say guaranteed, but you were very likely to have completed FD and DCT1 in 2 years, and you didn't have to apply for DCT1. So if you're really, for example, you want to be an orthodontist, for example, well, there's no real DCT1 ortho posts, really. It's all peds, special care, oral surgery, hospital based. So if you think, oh, actually, I love ortho, I really want to be an orthodontist, for example, I don't know who does, but I did know one person in my year who wanted to be an orthodontist, and she is an orthodontist. So you may just be happy to do any DCT1 post because it doesn't matter in the grand scheme of it. Does that make sense? That's how it works. So as long as you've the prerequisite to be in any particular pathway, you have to do DCT1. And usually, from what I understand, it doesn't really matter what you did DCT1 in. It's really then what you do DCT2 in, DCT3, and stuff like that.
Thank you. This one's for Sara. Would you say the white question SJT book that you use has questions that are as similar as possible to the actual SJT?
It's hard to say. I think I found the actual SJT a little bit harder than the white book. The white book also had a couple of mistakes, so I think they've like officially released like corrections for the book, so just bear that in mind when you're doing that book too. Again, the most realistic questions were the official Copden ones, I think.
Great. And one more question. Do you know anything about the academic clinical fellowship? It was asked on the oral application.
Right now, no. I apologise, I don't. However, there are academic FT posts. They started this year. I'm sorry, it just so happens that I'm not involved with the. I'm more FD, like historic FD, TPD. But if you want to find out more, then please email me, and I'll direct you to the right person. I don't know if that is that what you mean. Is it the academic FD posts? Because there are 2 of them this year. So basically, what I know about that is in the Northwest, they are in a Merseyside. At the moment, the 2 FDs are in a Merseyside practice, and they go to Liverpool Uni. And I think it's a little bit like the 2-year scheme in terms of they do so many days in practice and they do so many days in the uni doing research. But I'd have to clarify that. Don't take my word for it.
They said yes, thank you. That's all the questions that I have. Does anyone have any last minute questions that they want to ask? We've got nothing for the time being, but if you want to put your email address or your contact details, and if you're happy to put that in the chat, then people could send you an email if you have any more questions.
That's fine. I was just wondering, I did have a few more slides, so is it too late? Has everyone had? Is it too much to go on, or?
No, I think we can have a look at the slides if that's okay with you.
How easy is it to get a job as a dentist after finishing DFT? It is easy as whoever. Someone asked that just then in the chat. You will not have an issue getting a job, I promise you. And if you are all interested, I will talk more now about NHS dentistry and maybe get you thinking a little bit more. Do you want to have a break, or do you want me to just carry on? I don't want to bore anyone, you see.
I'm gonna head off just because I'm not home yet and I'm just really, really exhausted.
Oh, sorry, Sara. Sorry.
No, it's all right. But if anyone needs anything from me, then just message me.
Thank you so much.
No problem. Thanks for having
Thanks,
me.
Sara. Well done.
Thank you.
Bye.
Bye.
Sorry,
Yes, if you could carry on with the slides, that would be great.
Okay, just bear with me 1 second. So the reason why I wanted to ask you the question, so I'll just share the results. So can you see that? Yeah. So I sent this out just out of my own curiosity, and maybe just to share, you know, what you put in comparison to your peers. So 58% of you didn't really feel like you knew much about NHS dentistry. A lot of you were more confident with why the FD year existed. A lot of you don't know how general dental practices are funded, which I think is a big part of our job. And I think it's still important to know as an undergrad. 85% of you said no to how much an associate dentist is paid, which really interests me because sometimes money is a big factor in why you choose to be a dentist. Interestingly, loads of you knew what a UDA was, which I find funny that you don't know how much an associate dentist is paid, but you know what UDAs are, which is interesting to me. And then this was very much a mix of what general dentists usually are paid as, and I'll go through that in a second. And then my biggest interest, and I think the interest of the university will be, do you feel your university exposed you to life as a general dentist? And 74% of you said no, and there was 19% said maybe. And I think this is the reason why I'm now going to do this presentation, and hopefully it'll be a little bit more interesting. I'm just going to stop sharing this and put on the presentation now. So I hope this works. It went off before. So how much you know about the NHS system? So sort of just went through that. So this is how the NHS dental contract works, okay? So NHS funding is taxpayers' money, and sorry if this sounds patronising. And basically, NHS England has a general dental budget. I don't know how much that is. It doesn't really matter. We don't need to know the specifics. And then that money is commissioned to dental practices. And basically, nearly every dental practice in the country is a private entity. It is not part of the NHS. It doesn't exist. The only primary care element of that is part of the NHS are sort of community centres that have a primary care element. So you may be I don't know if Manchester go to community outreach, but they will have like a normal dental contract as well as a special care contract. So the money that's given to dental practices is up 99% always the same amount. So a dental practice will get the same amount every year. And this money is sort of converted to units of dental activity, so a UDA. So per UDA, the practice will be given a set amount. And then within the practice, the unit of dental activity is then divided usually between the associates. So let's just working really simply, if a practice is given 12,000 UDAs, and there are 2 dentists or 2 associates, if they work the same hours, they'll be given, just for example, they're given 6,000 UDAs each. And for the practice to be paid and the associate to be paid, or you as a dentist to be paid, you have to reach the target. That's how it works, okay? So purely NHS dentistry does not really exist. There's no such thing. It's something that we use as a flaky term, and the media use it as well. It doesn't really exist. No practice is truly an NHS practice because they are private businesses. Most dentists, so the question before, most dental associates are self-employed. And that is I'm not going to talk about being self-employed today. I can do in the future if it's something you're interested in, but it's very, very important to understand this as an undergrad. All these things I think are very important to your teaching. On average, a UDA target for a full-time dentist, I would say, in my opinion, it is around 6,000 to 7,000 UDAs. And to put that into context, how it works is that one, if you do a checkup or an exam, you get 1 UDA. If you do an emergency, it's 1.2 UDAs. If you do 1 filling or 20 fillings, it's 3 UDAs. And so on and so forth. And if you do a crown, it's 12 UDAs. But it doesn't matter if you do 2 crowns or 5 crowns, you get 12 UDAs. I would say right now in the UK, the average pay per UDA is £12. I'm pretty sure that's what it is. And it's not just as simple as being paid £12 per UDA, because, for example, if I see a patient tomorrow and I fit an upper partial denture, so I'll get £12 per UDA, I'll get 12 UDAs, so 12 times 12, but then I also pay half of the lab bill. So the practice receives a lab bill and I have to pay half out of my own earnings. That's how it works, basically. There are slight differences between practices, but that's in a summary. I'm just trying to make this easy and not complicated. So sorry, I'm just going to trace back. This is nothing to do with FD. You will not pay lab bills while you're in FD. This is if you are an associate. So jumping the gun, pretend you finished FD. So if you work in an NHS practice, what will you earn? So let's say you agree with your practice owner, target of 6,000 UDAs. So you just do simple maths, 6,000 times 12, 72,000. So that is your gross. But like I just said, you have to pay for lab bills. I use a random 7%. I find that an average associate will pay 7% lab bills. Some will pay more. So lab bills around £5,000, and you deduct that from the 72,000, and that's what you would earn about if you're only doing UDAs. But I've put there that you may have additional what we call private income. So for example, if a patient comes in and they want the teeth whitened, they want a nice composite filling, that's going to be hard, it's going to take you some time, and I could go on and on about additional private income. But it's really just to remind that you can do private work, but if you've agreed to do 6,000 UDAs, you have to do those 6,000 UDAs. You're contracted to do them. So let's just say you only do UDAs and you do 6,000 UDAs. So that's what you're going to earn, basically. So before tax, before student loan, before national insurance, before all these things you may not be aware of, you will get 66,900. So let's say 67 grand. So just to make it a bit more interesting, what does that actually mean in real life? So what will you have in your bank? So you'll have expenses. So you'll have to pay GDC, you'll have to pay indemnity or insurance, you'll have to pay for CPD, and you'll have to pay for equipment at some point in your career, and that will come off your tax bill. So just for ease, I'm not going into tax. And the good thing about the NHS is that you put into a pension. And at the moment, if you earn 66,000 around that, you put 12.5% into a pension. So I've used this website. So if you're interested and you want to work out how much you're going to earn when you graduate and you've done FD, just go to listentotaxman.com. It's just a really easy way of showing it. And what I'm going to do is I'm actually going to put that up now. So I'm just going to share a different screen again. I hope if I'm going too fast, please tell me. Hang on a second. So if in your first year, you're going to make around £67,000, this is how it's all calculated. So if you're going to do 6,000 UDAs and you earn £12 a UDA and you're going to pay 7% lab bill, as I've just said, this is what you're going to get in your pocket per month. So this is what you'll earn. This is what you'll actually have. So this is how much we pay in tax. There's national insurance. Actually, sorry, I've not done something. I've been evil and not put your student loan on there. Let me just make you all more depressed. So you pay student loan per month, national insurance per month, and all tax. So what looks like quite a big figure actually becomes a lot less. So it's a little bit depressing, but I assure you it's still quite a good amount of money, and you've still got potential to earn a lot more money than that as well. So I'm just going to go back to the presentation. Sorry, just going to find my slide. So I've been hearing that students already know why they don't like the NHS system. And a lot of it is because they don't agree with the fact that it's just target based on treatment and not prevention. The rules and regulation within the dental contract can be misunderstood and can cause confusion, even between people who have been dentists for a long time, get mixed up, don't really know what they can do, what they can treat, what they can claim. Many feel that they can earn more or the same, seeing less patients, basically, as a private dentist. And some feel they have to work quickly to be paid well. And I put that in those quotation marks. But I feel it's not all bad. And a reminder that when COVID happened and we couldn't see patients, all NHS associates were paid. They were paid what they were usually paid without seeing or doing UDAs. The other thing is that even though dental associates are usually self-employed, you're still able to get the NHS pension. And also sick pay and maternity pay is given, and that will not happen if you are purely a private dentist. If you're purely a private dentist, you're self-employed, you have nothing to do with the NHS, you won't get any sick pay or any maternity or paternity pay. So the other thing is that I feel like many don't understand the system, are quick to judge, and don't utilise the NHS system to its advantage as well. It's very cheap for the whole population. It's very, very cheap. Some patients are exempt. For example, under 18s do not pay for NHS treatment, and there's a lot of different exemptions that I won't go into today. And at the end of the day, the taxpayer, even though you've paid your student loans and you're paying tuition fees, the training of dentists is very expensive, and the taxpayer pay for us to be trained, and they don't pay for composite bonding or full rehab, Instagram things that you see by everyone who's doing that. We're trained to treat disease at the end of the day, and for me personally, I like working quickly, makes my day go fast, there's loads of problem solving, and I get paid well for it. And a load of dentists will say, no, you don't, you can earn more money in private. Well, that's fine, but I'm happy being an NHS dentist. So the other thing why in relation to sort of jumping the gun a little bit here with the presentation is I'm 8 years post FD, and I've really only been an NHS dentist more than I've ever been anything else. So I was a mainly private dentist for 1 year, but it just wasn't for me, and I preferred working in the NHS system. I've worked as a locum dentist, so that gives a lot of flexibility. I've worked for the emergency dental service, which again is NHS, so evening work means more money. I became an educational supervisor, 4 years qualified. You get a trainer grant, that's more money, that's NHS again. I like working in a high need area where patients appreciate basic general dentistry, just basically bread and butter, fillings, scaling, some crowns, some dentures, extractions, simple general dentistry that we should all be able to do. I've been on something what we call local dental network, so sort of attend meetings, discuss local issues, sort of public health based things, get paid for this through the NHS. I don't really have any personal interest in advanced cosmetics. It's not what I want to give to people. I don't really care. I don't have a passion for it. And when you become an FD or further on your career, it's fine. You don't need to be comparing yourself to your peers who are doing loads of stuff or loads of advanced cosmetics. And you're like, I don't really like that. Well, I don't. But one thing that I'm really involved with, as so we tell, is teaching and mentorship. And that's all me being an NHS dentist. That the only thing I've had to do in my career is I've done a PG cert in clinical education. I haven't had to spend loads of money on courses. I haven't had to do that. I've lived very well as in my career as an NHS dentist, and I will advocate that. It's not I'm worried about, but I find that what's happened is as the years are going by, the pressure of being a private dentist is becoming onto younger dentists, and I think it's trickling down into undergrads as well. And I'm at a point in my career where I could buy a practice if I wanted. Don't know if I do. Could maybe earn a little bit more money if I own a practice. But one thing I'm not as an NHS dentist is I'm not that stressed. I have my stress days, but that's the same for any job. I earn good money, and at the end of the day, I have a good lifestyle. So why am I going on about all this? And why am I sort of doing a sort of presentation? And personally, I have this sort of personal agenda to make university students more aware about their own courses. And this is maybe the controversial part of my talk. When you do your driving test, and if you drive, you learn to drive on the road. You don't drive in a car park. You don't drive on one road. You go out on the road with your driving instructor. And my comparison is that the dental hospitals are becoming like car parks. You're not exposed to the reality of our job, and you should be. You are going to be primary care based. I've just seen some of the questions. I'll try and answer that in a minute. So, most of you are going to be general practitioners, so you should know how to be a general practitioner with a BDS. You shouldn't need the FD year to give you that much of a base to change. The university should be supplying that already. And my opinion is a couple of days, weeks of outreach is not enough. You will not get exposure just with a couple of sessions of outreach. I went to UCLan. I was always in a primary care environment. I didn't need outreach, and I'm not trying to big up UCLan, but I'm just trying to say the difference is sort of coming. And also, how can you judge and feedback on your own training unless you know what you're doing? So really, you can only judge your training once you come out of uni. You can't judge it now because you're not on the road. You're only in the car park, so it's all artificial. And like I said, you can't go 20 miles an hour on a 30-mile-an-hour road. So what's the point in going 20 miles an hour when you'll never do that? Sorry. So this is a screenshot of my work in sort of our practice appointments. So you can see you can count how many patients I see between 9 o'clock and 11 o'clock. So on the left, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 patients between 9 and 11 o'clock. Yeah. So that's how many patients at least that you're going to see at some point. So the reality of that should be presented to you now, because what is the point in not knowing these things? This is your job. This is what you're going to do, maybe forever. So to the right, those two, so the purple and the yellow were the FD appointments of November last year. So you can see that, I don't know if you can see the date, it says 17th of November. So this is how many patients they were seeing in a couple of weeks into FD. And by the time you finish FD, you'll be almost up to my speed. But my point is that there should be more of an emphasis on you understanding where you're going to be soon. You shouldn't be just in the university bubble of seeing, one patient a morning. You should be pushed to do more. This is why it's controversial. So just to make you all aware that the GDC regulation of undergraduate teaching is not very strong, in my opinion. This is my opinion. And I think it's ironic. And as years are going by, FD seems to have done less. And it's definitely exaggerated the last 2 years because of COVID. But now COVID is becoming an excuse as well, in my strong opinion. And as students, your experience and your feedback is important. And like I said, but how do you know how good your experience is until you're out there? How can you know? You can't know for sure. You have to have that comparison. And my thing is that dentistry is vocational. The universities want to teach us gold standard, academic management, but you get better at it by doing it. And I don't go by gold when I treat my patients. Most dentists will not go by gold standard academic teaching. They will go by what's the quickest and what's the most efficient and what's the most ethical for that patient. And that's what you need to be taught. And you're the next generation of dentists. And so your experience is in everyone's interest. It's in my interest. It's definitely in my interest as being a TPD as well. So, like I said, I think that at the moment, the clinical experience could be a lot better, and pressure is needed on all of the dental schools. And this is my theory, is that it is becoming a lax to clinical experience. And the reason why I'm so passionate about this personally is because if you're more prepared for the FD year, then you'll gain more. So if you're all ready to go, you'll gain a lot more through your FD year, and you'll be more experienced by the time you're an associate, or if you are going to be an associate. This is very much associate driven, my presentation. And some FDs finish and they don't feel ready, and it shouldn't be that way. You should be ready when you finish uni, really, shouldn't you? You've been to uni for 5 years. So what the BDS has to excuse, I don't really know. And just a reminder, dentistry is performed in primary care on the high street. It's not done in a dental hospital. So take home message, shouldn't be a huge transition in my opinion. Put your pressure onto your educators and ask what would we do in primary care, what would we do in practice, in reality. Get them thinking. Start to push yourself now with what you want to concentrate on. Don't take 30 minutes to take a plaque and bleeding score, because no dentist in the country, private or NHS, takes 30 minutes to do a plaque and bleeding score, because you won't get paid. And if it takes you 30 minutes to do a plaque and bleeding score and a perio chart, how do I see a patient for an exam in 10 minutes? Yeah, so it's just to sort of voice this message. And just think about what you may do in general practice, especially during 5th year. You need to start getting your general practice head on, because that's what you're going to be working in. And try and understand the NHS system now, because like I said, when you learn to drive, you tend to know the road already. You don't practice to drive on a false road, do you? You're out there already, and you know the traffic lights and you know the roundabouts. So that's my little comparison. So just to finish off, good luck with your final year, your 5th years, and main advice is never get stressed about dentistry, because they're only teeth at the end of the day. And that is it. And obviously any questions, happy to take. So someone asked before, I did see one question, how is it possible to meet a target of 6,000 UDAs? Well, it's very possible. I promise you I do it. But you won't have an hour and a half for a treatment plan session. You'll have 10 minutes. It will happen, I promise. But the shock is maybe needed now. Any other thoughts or questions?
I think that's all. Thank you so much. I'll just hand over to Aisha, who will finish off the meeting, if that's okay.
No worries, thank you.
All right, thank you everyone for tuning in with us tonight. We hope you all have learned something from today, which will help you ace your SJT. A big thanks to Dr. Sara Member and Dr. J for being part of our first event of the year. Thank you so much for your presentation and the time that you spent with us tonight. I'm sure the information given will prove to be invaluable in the DFT application and the career beyond. If anyone has any questions that they didn't get to ask or anything they'd like to say, please drop a message on any of our social medias. Thank you to you guys as well for making it this far and attending our first event of the year. Good luck, and we wish you all the best.
Thank you.
Thank you. If anyone wants to email me, you're very welcome if you need any advice or anything like that.